Aortic valve disease, aortic stenosis, and aortic regurgitation, and finally aortic valve surgery. Aortic stenosis includes pathophysiology, clinical features, investigations, and indications for surgery. Same in case of aortic regurgitation. Aortic valve disease. Approximately 2/3 of all valve surgery performed in UK is for aortic valve disease, which remains common despite a reduction in the incidence of rheumatic fever in resource-rich countries. Aortic stenosis. Aortic stenosis. Aortic stenosis, as opposed to aortic sclerosis. Aortic sclerosis occurs when a pressure gradient can be demonstrated across the aortic valve. The difference is not absolute, as sclerosis in adults is an acquired degenerative calcific process that results in immobile aortic valve gasp. Progressive fibrosis and calcification of a congenitally abnormal valve can mimic this degenerative process. The usual congenital abnormality is commissural fusion, leading to a bicuspid aortic valve, which occurs in approximately 1% of the population. Aortic stenosis is opposed to aortic sclerosis. Occurs when a pressure gradient can be demonstrated across the aortic valve. Occurs when a pressure gradient can be demonstrated across the aortic valve. The difference is not absolute, as sclerosis can progress to stenosis. The common cause of aortic stenosis in adult is an acquired degenerative calcific process that results in immobile aortic valve gasps. Progressive fibrosis and calcification of a congenitally abnormal valve can mimic this degenerative process. The usual congenital abnormality is commissural fusion, leading to a bicuspid aortic valve, leading to a bicuspid aortic valve, which occurs in approximately 1% of the population. Now, pathophysiology. A pressure gradient develops between the left ventricle and the aorta. With the left ventricle adapting to this systolic pressure overload by an increase in left ventricular wall thickness or hypertrophy. This adaptive response is an attempt to normalize left ventricular wall stress in the face of increased left ventricular systolic pressure and may maintain a normal cardiac output, prevent left ventricular dilatation, and avoid significant symptoms for a number of years. Eventually, myocardial function is affected, and together with insufficient left ventricular hypertrophy to normalize wall stress, load mismatch, ventricular contractility is reduced. When aortic stenosis is severe and cardiac output is normal, a greater than 50 millimeter of mercury gradient between peak systolic left ventricular and aortic pressure exists. As aortic stenosis worsens, becomes insufficient at rest, the reduction aortic stenosis pathophysiology. 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 A pressure gradient develops between the left ventricle and the aorta. Pressure gradient develops between the left ventricle and aorta. Between the left ventricle and aorta. With the left ventricle adapting to the systolic pressure overload by an increase in the left ventricular wall thickness or hypertrophy. Increase in the left ventricular thickness or hypertrophy. This adaptive response is an attempt to normalize left ventricular wall stress in the face of increased left ventricular systolic pressure. Increase left ventricular systolic pressure, and may maintain a normal cardiac output. Prevent left ventricular dilatation. Prevent left ventricular dilatation and avoid significant symptoms of a number of years. Eventually, myocardial function is affected. Eventually, myocardial function Eventually, myocardial function is affected, and together with insufficient left ventricular hypertrophy to normalize all stress load mismatch, ventricular contractility is reduced. When aortic stenosis, when aortic stenosis when aortic stenosis is severe and cardiac output is normal, a greater than 50 millimeter of mercury gradient between the peak systolic left ventricular and aortic pressure exists. Left ventricular pressure and aortic pressure exist. As aortic stenosis worsens, cardiac output cannot increase with exertion and eventually become insufficient at rest. The reduction in ventricular contractility leads to an irreversible decline in left ventricular function with dilatation, and a rise in the left ventricular end diastolic pressure, and a rise in left ventricular end diastolic pressure to the point of the overt left heart failure. Now, clinical features. Patients are often asymptomatic until decompensation occurs. Typically presenting with dyspnea and angina. Typically presented with dyspnea and angina, which is due to increase oxygen needs for the hypertrophied left ventricle, reduced coronary filling, and inadequate cardiac output during exertion, which is due to increased oxygen needs of the hypertrophied ventricular muscle due to increased oxygen need, reduced coronary filling, and inadequate cardiac output. Reduced coronary filling and inadequate cardiac output during exertion. Patients often describe a feeling of lightheadedness or near syncope on effort. Lightheadedness or near syncope on effort, or near syncope on effort. Cardiac arrhythmias can also occur. Cardiac arrhythmias. Cardiac arrhythmias can also occur. Auscultation of the heart demonstrates a murmur that is typically harsh, ejection in nature, and based hard over the aortic area with radiation to the carotids of the heart demonstrate a murmur. With critical aortic stenosis and a fall in cardiac output, the murmur may become quieter. The apex beat may be displaced in late disease along with signs of cardiac congestion. Features and pathophysiology of aortic stenosis. Hemodynamic changes in aortic stenosis. Aorta with post-stenotic dilatation. Hypertrophy with raised systolic pressure on 80 millimeter of mercury, 10 to 15 millimeter of mercury. Here 120 by 80 millimeter of mercury. Investigations. ECG, ECG number 1 investigation includes ECG number 1 ECG. There is left ventricular hypertrophy. There is left ventricular hypertrophy. Left ventricular hypertrophy with tall R waves in the lateral heads and sometimes a strain pattern ST depression with inverted T waves in the lateral leads. So findings are there is left ventricular hypertrophy with tall QRS or R wave, tall R wave in the lateral leads and sometimes a strain pattern. Strain pattern, that means ST depression. This is called strain pattern. ST depression with inverted T waves is in the lateral leads. Chest radiographs may be normal. Cardiomegaly and pulmonary congestion can be seen in the presence of left ventricular failure. Post-stenotic dilatation of the aorta is occasionally seen. Chest X-ray in aortic stenosis may be normal. Cardiomegaly ratio more than 0.5. Cardiomegaly and pulmonary congestion can be seen in the presence of left ventricular failure. Post-stenotic dilatation of the aorta is occasionally seen. Echocardiography Echocardiography confirms the diagnosis. Echocardiography confirms the diagnosis and together with color flow Doppler imaging allows assessment of the aortic valve gradient, calculation of the valve area and evaluation of the left ventricular dimensions and wall thickness. Allows assessment of the aortic valve gradient aortic valve gradient calculation of the valve area and evaluation of the left ventricular dimensions and wall thickness Coronary angiography to investigate the coronary arteries in patients with greater than 40 years of age. Indications for surgery. Indications for surgery in case of aortic stenosis. Medical management focus on the avoidance of systemic hypertension and arterial dilatation, which may reduce myocardial perfusion pressure and therefore provoke ischemia. The natural history of symptomatic patients with aortic stenosis is dismal, with a 10 years mortality rate of 80 to 90%. The patient is at risk of sudden death related to severity of the stenosis. severe symptomatic aortic stenosis means gradient. Severe means gradient greater than 40 millimeter of mercury, velocity greater than 4 meter per second, and aortic orifice area less than 1 centimeter square are indications for surgery. Surgery is indicated in asymptomatic patients with severe stenosis. Severe stenosis impaired left ventricular function, or when the patient is undergoing surgery for a different reason such as CABG. An abnormal blood pressure response to exercise. Low blood pressure is also a sign. Low BP is also a sign. That there is limited reserve in asymptomatic patients. Now, aortic regurgitation. Aortic regurgitation. The causes of aortic regurgitation can be classified according to the speed of development of regurgitant jet, acute or chronic, or according to anatomical location of the pathology, valve leaflet or aortic wall. The cause of the acute aortic regurgitation include endocarditis. Causes of acute aortic regurgitation include infective endocarditis, aortic dissection, and trauma. The common causes of chronic aortic regurgitation include degeneration leading to aortic root, degeneration leading to aortic root degeneration, and or annular dilatation, congenital bicuspid instead of tricuspid valve, and previous rheumatic fever or endocarditis. Causes of aortic regurgitation. According to predominant anatomical location of the pathology, valve leaflet disease, aortic wall pathology, congenital rheumatic heart disease, infective endocarditis. Congenital example, bicuspid valve leading to degeneration changes occasionally with the ventricular septum. This is bicuspid valve. Aortic wall pathology, inflammatory systemic disease and degenerative disease. Inflammatory disease example, connective tissue disorders such as ankylosing spondylitis, systemic lupus erythematosus or SLE, then rheumatoid arthritis or RA. Systemic disease include tertiary syphilis, degenerative Marfan syndrome, aortic root dissection, senile aortopathy leading to aortic root or annular dilatation. Pathophysiology. Acute aortic regurgitation Acute aortic regurgitation imposes a volume load on the left ventricle because of backflow. Pathophysiology. Acute aortic regurgitation imposes a acute volume load on the left ventricle because of backflow. It causes a sharp rise in the left ventricular end diastolic pressure. Premature closure of the mitral valve. And inadequate forward left ventricular filling. The result is sudden hemodynamic deterioration. The result is sudden hemodynamic deterioration and acute respiratory compromise. The result is sudden hemodynamic deterioration and acute respiratory compromise. In case of chronic aortic regurgitation, volume load and left ventricular end diastolic pressure. Left ventricular end diastolic pressure increases gradually, leading to compensatory left ventricular dilatation. And eccentric hypertrophy to maintain adequate cardiac output. And eccentric hypertrophy to maintain adequate cardiac output. Systolic and diastolic function is abnormal and sudden deterioration can occur. Clinical features. Long-standing aortic regurgitation is usually asymptomatic until the left ventricle begins to fail. When exertional dyspnea may be the only symptom. Angina can also develop. Dyspnea angina can also develop. A wide pulse pressure due to reduction in diastolic pressure and collapsing pulse, Otter-Hammer pulse, are commonly seen. Other manifestations of the wide pulse pressure include visible capillary pulsation of the nail bed. Other manifestations of the wide pulse pressure include visible capillary pulsation of the nail bed, also called Quincke's sign. Pulsatile head bobbing known as de Musset sign. Visible arterial pulsation in the neck, known as Corrigan's sign. A pistol shot sound on oscillating over the femoral artery. This is called Traubus sign. And uvular pulsation known as Mueller's sign. Mueller's sign. The apex is displaced laterally, often visible and hyperdynamic or thrusting in nature because of the left ventricular hypertrophy. Auscultation reveals a high-pitched early diastolic murmur-based heart at the left sternal ace. Left sternal ace. Hemodynamic consequences of the aortic regurgitation. The left ventricle dilates. The left ventricle dilates and hypertrophies, and there is a diastolic murmur. A left atrial pressure 100/0 millimeter of mercury. Left atrial pressure. Aortic regurgitation 20/40. Investigations. Investigations includes investigations for aortic regurgitation. Number 1, ECG. This is left ventricular. There is left ventricular hypertrophy. And sometimes a strain pattern. Chest radiography, chest X-ray or chest radiography. Cardiomegaly can be seen in left ventricle is in the left ventricular is dilating. Sometimes the aortic shadow may also indicate dilatation. So here we will see cardiomegaly. Number 3, echocardiography. This allows assessment of the underlying cause and severity of the aortic regurgitation. Hence, cause and severity of the aortic regurgitation, and enables the diameter of the aortic root, as well as diameter of aortic roots. Measurement of the aortic diameter of the aortic root, as well as left ventricular dimension to be determined. Color flow Doppler imaging quantifies the size of the regurgitant jet. Coronary angiography, to investigate the coronary arteries in patients greater than 40 years of age. Number 4, coronary angiography, greater than 40 years of age. Indications for surgery. Finally, indications for surgery. Medical therapy with vasodilator drugs for relief dyspnea or angina is designed to improve forward stroke volume and reduce regurgitant volume. Medical therapy with vasodilator drug. Vasodilator vasodilator drug to relief of dyspnea or angina. However, symptomatic relief does not alter the need for valve surgery. The indications for surgery include severe regurgitation in symptomatic patients. The indications are severe regurgitation plus in symptomatic patients. Asymptomatic patients with severe aortic regurgitation plus asymptomatic patients and left ventricular dysfunction should be offered surgery. And left ventricular dysfunction. Valve replacement should also be considered. Valve replacement should also be considered in asymptomatic patients with severe regurgitation. In case of this valve replacement should also be considered if they are undergoing cardiac surgery for any other reason or when there is evidence of progressive left ventricular dilatation. Left ventricular end diastolic diameter is greater than 50 millimeter of mercury. Aortic valve replacement is recommended if there is a decrease in systolic function. Now, aortic valve surgery. Aortic valve surgery. Aortic valve surgery includes aortic valve replacement and transcatheter aortic valve implantation. Aortic valve replacement and transcatheteric aortic valve implantation. Aortic valve surgery. Unlike mitral valve surgery, there are few occasions when the aortic valve can be repaired, and usually the valve requires replacement. More replacement is better than repair. However, in neonates and children, aortic valve repair or valvotomy is well established. Repair is well established for neonates and children. Percutaneous aortic balloon valvotomy has a role in children. Percutaneous aortic balloon valvotomy has a role in children, but appears to only result in temporary benefit in adult aortic valve disease. So, aortic valve replacement is performed. Aortic valve replacement or AVR is performed through a median sternotomy on CPB. Is performed through a median sternotomy on CPB, cardiopulmonary bypass. The aorta is cross-clamped The aorta is cross clamped. The aorta is cross clamped and open proximally to reveal the diseased valve. Cardioplegic solution is infused. Cardioplegic solution is infused into the coronary arteries. These are the coronary arteries. Cardioplegic solution is infused into the coronary arteries to arrest the heart in diastole. The valve is then excised, leaving the annulus in situ but removing as much as calcific debris as possible. The annulus is seized and mechanical or biological valve is then sutured into position at the level of native annulus and the aortomy is closed. Aortomy is closed. The operative mortality rate for elective aortic valve surgery is 2 to 3%, but is higher in emergency surgery, in surgery for endocarditis, and in old patients. Major complications includes stroke 2%, postoperative MI 2 to 3%, but in higher in emergency surgery, in surgery for endocarditis and heart block requiring a permanent pacemaker, the 1%. The major determinant of late survival after aortic valve surgery is preoperative left ventricular function. The 5-year survival rate is approximately 75 to 85%, with the majority of the late deaths related to myocardial factors. Transcatheteric aortic valve implantation. Although AVR is still the gold, aortic valve replacement is the gold standard treatment. A significant number of patients affected by severe aortic stenosis is requiring AVR do not undergo surgery because they are considered too old or too frail for such an invasive procedure, or because they are affected by concomitant comorbidities that noticeably increase the operative risk. In such patients, transcatheteric aortic valve implantation, in short, transcatheteric aortic valve implantation, TAVI. TAVI is attractive alternative to standard aortic valve replacement. Other indications include heavily calcified ascending aorta, porcelain aorta. Heavily calcified ascending aorta is called porcelain aorta, and the presence of a severe congenital thoracic distortion There are different approaches for valve implantation. The most commonly used are transapical, antegrade, and transluminal or retrograde approach. Transapical approach. The main advantage of performing transapical procedures is that the feasibility does not rely on the absence of a concomitant peripheral vascular disease or previous aortic surgery. This approach reduces the risk of calcium dislodgement due to the passage of a strip transluminal device into a diseased aortic arch. In transapical approach, TAVI, transcatheteric aortic valve implantation. The cardiac apex The cardiac apex is prepared through a small left anterolateral mini thoracotomy. Left anterolateral mini thoracotomy using a purse string or cross suture reinforced by plates, and after the procedure a chest tube is routinely inserted into the left pleura. A purse string or cross suture is used. Purse string or cross suture. Transluminal approach. This can be carried out. Transluminal approach. This can be carried out via the femoral or subclavian artery. Femoral artery or subclavian artery. This is a useful technique for patients with previous cardiac surgery. However, the presence of peripheral vascular disease, small vessel diameters, tortuous vessels, aortic disease, or previous aortic surgery contraindicates this approach. Whichever approach is used, a balloon catheter is advanced into the left ventricle over a guide wire and positioned at the opening of the aortic valve. The existing aortic valve is dilated in order to make room for the prosthetic valve. A rapid right ventricular pacing is used to interrupt cardiac output through the existing aortic valve and to reduce movement during implantation. The new valve mounted on a metal stand is manipulated into position and is either self-expanding or deployed using balloon inflation. Deployment leads to obliteration of the existing aortic valve. Complications associated with TAVI include mortality 5 to 18% at 30 days, mild to moderate aortic regurgitation 30 to 50%, stroke 3 to 9%, perioperative open conversion 9 to 12%, vascular complications 10 to 15%, and atrioventricular block 48%. A recent MI less than 3 months, severe pulmonary dysfunction, and presence of an apical thrombus are contraindications for transapical TAVI. Interestingly, most recent multi-care trials have demonstrated that the role of TAVI can be expanded to include intermediate risk patients with satisfactory 2 years outcome.